I'm Dr. Marie Gabe-Walters and I'm a national researcher working with the Lymphoedema Network Wales, and I'm here today to talk about a project which explored the impact of Covid-19 and opportunities for learning on lymphoedema services in Wales. Lymphedema is a lifelong condition with a hallmark of chronic swelling. It can be present from birth or secondary to an event such as cancer or trauma to an area of the body. Regardless of etiology, it has profound and lifelong physical and psychosocial morbidity which can affect activities of daily living, impair quality of life, lead to isolation and impair ability to seek employment. The prevalence is not well understood, but a recent Welsh audit suggests a prevalence of 6.48 per thousand population. The management of lymphedema relies on daily skincare, exercise, compression and lymphatic drainage, along with education and support. So for this reason, lymphedema has traditionally relied on partnership between the patient and the clinician or the therapist, along with hands-on care. However, the COVID-19 pandemic of 2020 curtailed all hands-on face-to-face services. As a result, lymphedema services across Wales were scoped for their impact. The aims of this study was based on the scoping exercise with a view to capture ways of working, learning opportunities and impact on staff, clinical and non-clinical, in lymphedema services. An online survey was developed based on scoping and was hosted anonymously for a 3-week period in June. All staff affiliated with the lymphedema services in Wales were contacted via email for participation in the survey, with the survey being available bilingually in English and in Welsh. Data were analysed by 2 researchers who were independent of service delivery, and the research and governance approval was given as service evaluation. A response rate of 49% was gained, covering respondents working from home and those deployed to sectors outside of lymphedema. Of those deployed, there were 3 main areas: primary care, secondary care and COVID testing units. When asked about preparation or support for this new role, the majority of staff felt well prepared and supported. Preparation was cited in terms of training or access to induction and shadowing staff on the wards. And for some, having had recent experience in that area was seen as a benefit, whereas for others it was seen as an expectation that they could hit the floor running. The majority of staff cited support in terms of working together as a common goal, having colleagues that showed concern and went the extra mile to help one another. When asked to think about any learning opportunities that could be brought back towards the lymphedema services from the area of deployment, staff identified that collaborative working in the community with district nurses was beneficial for patients with complex lymphedema. Virtual services done elsewhere helped services work efficiently and prioritise contact. Action logs and documentations and operating procedures not only enabled services to maintain an element of business continuity, it was also seen as a way to prepare for future action should another disruption to services occur. When asked about personal protective equipment, overall, staff felt that it was adequate, but a small number also reported some concerns with their access to adequate PPE. These concerns, whilst not many, were significant and substantial for each of those that reported them. So when asked what lymphedema services could teach other services, the majority of staff focused on education opportunities in primary care and in secondary care. Opportunities to address knowledge deficits or lack of confidence in recognising and knowing about lymphedema, along with referring patients to services. In terms of referral, it was also identified that services were not always aware that the lymphedema services maintained action during the COVID-19 pandemic, and so were able to refer at all points through 2020. There was also lack of confidence and sometimes willingness to adopt management techniques and adhere to care pathways that exist. When asked about stress and support for staff, The majority reported an increase in their overall anxiety at home and at work. And this concern was also hindered by changeability at home and at work, and concern for health of family and friends, along with the risk of a surge in patients when services finally resumed to their new normal. Some staff were also anxious about not working on the front line supporting their colleagues. On the whole, informal support for all of these staff were gained from family and friends, along with colleagues. When asked what the patient's responses were to being contacted during the lymphedema, during serious lockdown with lymphedema, overall patients welcomed contact and were grateful to be able to support and have advice around any concerns that they had, also enabling them to order garments and identify need for face-to-face services with deterioration of lymphedema. Patients were considered potentially better able to manage, though there were concerns around weight gain and lack of exercise during the lockdown period. Lymphedema services on the whole continued to deliver virtual contact throughout the pandemic period. And in fact, lymphedema services across Wales made use of processes that were already underway to establish virtual care within value-based healthcare. Interestingly, 13% of patient contacts were still face-to-face during the lockdown period, and virtual care was seen as a way to prioritise these face-to-face appointments. When asked to think about which groups of patients would likely benefit from virtual, which is video and telephone-based contact, a majority of respondents felt that those in the risk reduction group or with mild to moderate lymphedema were likely benefit and suitable. And benefit was thought about in terms of safety, minimising risk and supporting shielding, ensuring support, and promoting value-based healthcare, triaging and prioritising needs whilst minimising wasteful contact. And these benefits not only apply to this top group, but also cascaded through to the more complex lymphodemas. Having said this, the more complex lymphodemas, you can see the benefit or the reported benefit by staff, likely benefit, decreases, whilst the suitability also becomes a concern. Suitability was questioned in terms of being able to access all the information you need to make a judgment. It's the lack of touch, the lack of sight, the reliance on subjective patient reports was not always deemed accurate and appropriate. And also the characteristics, the ability of the patients to use virtual services, and also the changeability of their lymphedema may impact on whether or not they'd be suitable for ongoing virtual care. So what next? Education initiatives are underway, including the on-the-ground education project and local health board delivered initiatives such as link roles. These will help ensure that awareness of lymphedema is raised and that staff feel confident and competent to refer or instigate management using care pathways. Virtual and value-based healthcare, as I mentioned earlier, was already underway within the Lymphedema Network Wales, but the Covid-19 pandemic has expedited all of the work that was expected to take place over the coming months to year. Having standard operating procedures in draft and documentations before the pandemic enabled staff to swiftly move towards virtual ways of working. Teamwork and face-to-face contact is never to be underestimated. Staff working from home, some all of their time, and those deployed to other areas needed that support. So moving forward, we need to understand the patient experience, the ability to self-manage, and the impact on lymphedema services, along with the suitability and impact of virtual care. Thank you for your time and for listening today. Please feel free to email myself any questions, and many thanks to all the respondents of this evaluation and for all of those that supported lymphedema services during this difficult time.